Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Standard Medical Notes or Lecture. So this will be the last topic of our series of diabetes mellitus. So everything we have discussed in the topic of diabetes mellitus. So let us complete this last topic. So that is diabetes in pregnancy and gestational diabetes mellitus. So remember, these both of these terms are different actually. Diabetes in pregnancy and gestational diabetes mellitus. Diabetes in pregnancy is nothing but it can be either gestational diabetes mellitus or it can be a pre-existing type 1 or type 2 diabetes mellitus. So that is diabetes in pregnancy. But what is gestational diabetes mellitus? So the woman is not having diabetes mellitus previously and she has developed diabetes mellitus either in the second or third trimester. So that is gestational diabetes mellitus. So diabetes mellitus in pregnancy is nothing but it is a broad term which encompasses both gestational diabetes mellitus as well as a woman of type 1 diabetes mellitus or type 2 diabetes mellitus who is pregnant. Whereas gestational diabetes mellitus is a diabetes which develops during pregnancy. Okay, that one clearance was needed. Now, so what's the definition now? What is the definition? So we will have some overview about this. Okay. So what is GDM? Glucose intolerance first detected in the second or third trimester of pregnancy. Not clearly overt diabetes prior to gestation. Overt diabetes prior to gestation is but a hyperglycemia and a symptomatic diabetes before becoming pregnant. Okay. So it is detected during second or third trimester, but the woman was not having diabetes, symptomatic diabetes before becoming pregnant. So that is GDM. So previous existing diabetes, overt means symptomatic diabetes in pregnancy. Known type 1 diabetes mellitus or type 2 diabetes mellitus diagnosed before conception, or overt diabetes which is detected in first trimester. Remember, if a pregnant woman is detected to have hyperglycemia in the first trimester, then it is not considered as GDM, but rather it is considered as overt diabetes. Okay. So why should we study this one? GDM affects 10 to 15% of all pregnancies globally, and in India it is up to 20 to 25% in urban cohorts. So 1/4 of the pregnant ladies. It is the single most common metabolic complication of pregnancy, with consequences spanning both mother and fetus across generations. Okay. Now, so same thing, summary. So pre-existing type 1 or type 2. So when we call it as pre-existing, so either it is before pregnancy or in the first trimester. Okay. GDM, when we call it as GDM, either it is diagnosed in second or third trimester, and it is usually asymptomatic. By screening it is detected. Symptomatic diabetes mellitus in pregnancy is usually detected in first trimester or a new diagnosis. HbA1c of the lady will be more than or equal to 6.5%. Fasting plasma glucose will be more than or equal to 126 mg per deciliter. These should be treated as pre-existing because this is diagnosed in first trimester or of pregnancy. That is the take home message. Okay. Now, so it is a common complication. Okay. Screen between 24 to 28 weeks to detect GDM. Identify and manage early to improve maternal fetal outcomes. Impacts both present pregnancy and future metabolic health. Now, what are the features? So we will focus up on the gestational diabetes mellitus. What are the clinical features? We can divide the clinical features into maternal symptoms, which are suggestive but not diagnostic. Obstetric red flags. So either some clues which we get on examination or clues which we get on sonography, or neonatal features, the clues which we get by seeing the neonate, so at delivery. Okay. So what are the maternal symptoms? So symptoms of polyuria, polydipsia, recurrent vulvovaginal candidiasis, unexplained fatigue. So these are the common symptoms. Polyuria, polydipsia. Okay, you need to differentiate it from urinary tract infection, which is very common in pregnant ladies. Okay, So polyuria, polydipsia, unexplained fatigue. Again, UTI also causes unexplained fatigue. Recurrent vulvovaginal candidiasis. Candidiasis is common during pregnancy, but if it is recurrent, then you should think of diabetes. Okay. So this we should remember. Most GDM is asymptomatic, detected only on screening. Clinical features when present suggest either. So remember, it is symptomatic. It is detected only on screening. If a pregnant lady presents symptoms of diabetes mellitus, then most likely it is overt diabetes, meaning she is having type 1 or type 2 diabetes mellitus or severe disease. So on examination, so she will have fundal height more than the dates. So if she has fundal height more than the dates, meaning if on examination on the of the abdomen, if 20 weeks are passed according to her last LMP, and on abdominal examination someone is getting 24 weeks by abdominal examination, then that means fundal height is greater than the dates last LMP, meaning the height depending upon the LMP. So that means the baby is bigger. So that is a clue for diabetes GDM. And fetal macrosomia, so this is detected by your obstetric scan. And another important thing is polyhydramnios on ultrasound. Why? Fetal hyperglycemia causes polyuria. So because of polyuria, there will be increased fluid, amniotic fluid. So that is polyhydramnios, increased fluid. So that suggests GDM. So this is GDM. These are the clues. Okay, abdominal examination and obstetric examination of the parameters of the neonate or seeing the fluid. Hypertensive disorder score presenting. So if a lady has hypertension, it may be pregnancy induced hypertension or a hypertension before pregnancy, so that lady has a high risk of diabetes mellitus. So neonatal features: if the birth weight of neonate is more than 4 kg, then you should think the lady must had GDM. Neonatal hypoglycemia, very important. Why? Because there was increased sugar levels in the mother, so that causes hyperinsulinemia in the baby also. Hyper meaning the baby's body will secrete increased insulin to tackle the increased glucose levels, but when it comes out of the mother, the glucose levels are not high now, but the insulin levels are low, so baby will develop hypoglycemia. So neonatal hypoglycemia is a clue for gestational diabetes mellitus. And a neonate who develops respiratory distress syndrome, or a neonate who develops jaundice and polycythemia. So all these are features. So abnormal jaundice and polycythemia, respiratory distress, okay, respiratory distress, neonatal hypoglycemia, macrosomia. So all these 4 important features point out towards gestational diabetes mellitus: jaundice, polycythemia, macrosomia, neonatal hypoglycemia, and respiratory distress. Okay. So how do you screen for this gestational diabetes mellitus? You screen by seeing the risk factors in the lady. Okay. So risk factors, we classify them as low risk, moderate risk, and high risk. So for high risk ladies, we should screen at first visit. For moderate risk, we should screen at 24 to 28 weeks. For low risk, we should not. We may differ. We may omit. Okay. If you don't screen, then it is okay. So we should remember these things, these 2. Okay. What are the high risk features which suggest screening at first visit? If the BMI is more than 25, or if she is an Asian girl, and the BMI is more than 23. So any Asian girl, like in India, okay, India, Bangladesh, Pakistan, okay, all. So if an Asian girl is pregnant, then that itself is a high risk feature. So it should screen at first visit. So previous history of diabetes in pregnancy, previous GDM. Previously the baby was more than 4 kgs, macrosomic baby, or first degree relative having type 2 diabetes mellitus. First degree relative meaning a sister or brother or son or mother or father. These are our first degree relative. Having type 2 diabetes mellitus is a high risk feature. Macrosomic previous history, macrosomic baby or previous GDM or Asian girl. History of PCOS, polycystic ovarian syndrome, is also a risk factor, high risk factor for GDM. Previous unexplained stillbirth or intrauterine death. What is stillbirth? So death meaning uterus will lose the baby about 20 weeks. Uterus will lose the baby about 20 weeks and the baby will die outside the mother wombs. So before 20 weeks it is called as abortion. So you can think stillbirth as abortion after 20 weeks. So abortion after 20 weeks is known as stillbirth. And intrauterine that without any cause. So that is also so 20 weeks meaning 5 months. So above 5 months if there is abortion, so that is stillbirth. So if the HbA1c before pregnancy was 5.7 to 6.4, which is a category of pre-diabetes, so then that is a high risk factor for GDM. And use of glucocorticoids, for example, if she is a asthmatic patient or she is taking or she is having some connective tissue disorder for which she is taking glucocorticoids, then again she is a high risk lady for having gestational diabetes mellitus. So a obese lady or an Asian lady or who has a previous high weight baby or macrosomic baby, I can say, previous history of GDM, history of polycystic ovarian syndrome, okay, and history of intrauterine, no without any cause intrauterine death, history of stillbirth, history of glucocorticoid use, history of a first degree relative of type 2 diabetes mellitus. All these are high risk factors. We should ask these things. So these include previous history, this is family history, this is personal history. Okay, previous pregnancy history is very important. So to remember, we can divide it as, so this is actually previous pregnancy history, okay, and this is family history, this is personal history, previous pregnancy history, family history and personal history. Okay, moderate risk patients like a female who is aging 25 to 34 years of age, or ethnicity of South or East Asian, Hispanic or African, or known risk factors at first visit. Then we can these three things: female age 25 to 34 years, ethnicity, and no risk factors in the first, meaning there are no risk factors. So every woman should be screened for GDM at 24 to 28 weeks if they are not having any risk factor. So low risk meaning if she is very much young, like less than 25 years of age, BMI is less than 23, thin lady, no family history and no adverse obstetric history, no previous, for family history is okay, and previous pregnancy history is also okay, and her age and weight are very important. So age is less than 25 years and obesity meaning BMI is less than 23, so no need to screen. Actually these are low risk females. So early females like less than 25 years of age, BMI less than 23, no family history, no previous pregnancy, adverse obstetric history. So one point to remember here is Indian specific. South Asian women carry inherent insulin resistance risk. Screen all pregnancy at first antenatal visit regardless of risk stratification. So for India, we don't need to risk stratify any pregnant woman. We should straightforward screen at the first visit only. Okay, that we should remember. So this is DIPSI recommendation, diabetes mellitus. Okay, DIPSI is a study group, so that recommendation. Now what are the differential diagnosis of hyperglycemia in pregnancy? Hyperglycemia, you can't say it is only diabetes mellitus, so it can be a symptomatic diabetes mellitus in pregnancy, okay, or it can be impaired fasting glucose, meaning you can say impaired glucose tolerance, or it can be stress induced hyperglycemia, so she has developed some illness and because of that she has developed hyperglycemia, or steroid induced hyperglycemia. Okay, then So this is not important. Okay. Cushing syndromes in pregnancy, this is also rare actually. Okay. Or it can be type 1 diabetes mellitus. Remember, the important one, differential diagnosis of hyperglycemia in pregnancy are, so it can be either type 1 or type 2 diabetes mellitus, or second it can be stress hyperglycemia, or it can be steroid induced hyperglycemia. Stress, steroid, type 1 and type 2 diabetes mellitus. Okay, so these are rare cases, Cushing syndrome presenting or MODY. Okay, maturity onset of diabetes of the young. So these three are important: stress induced hyperglycemia, steroid induced hyperglycemia, or type 1 and type 2 diabetes mellitus. So key differentiator here is, any hyperglycemia detected in the first trimester is likely symptomatic diabetes mellitus and not gestational diabetes mellitus. GDM is a diagnosis of second or third trimester, that we should remember. Okay. Now, how do you screen? That is important. So I said for India, because I do reside in India, I practice in India. So for Asian women's, or like in India, we should screen at the first antenatal visit. So what test we use for those? So we use two things. One is fasting plasma glucose. Second one is HbA1c. Okay, FPG and HbA1c. So if fasting plasma glucose is more than 126 milligram per deciliter for 2 times, so 2 times you should check, 2 readings you should take. So then that is likely symptomatic diabetes mellitus and not gestational diabetes mellitus. If the fasting plasma glucose is 92 to 125 milligram per deciliter, then that is gestational diabetes mellitus. Okay, that is not over diabetes mellitus, that is gestational. So to say it as gestational, and if the fasting plasma glucose is less than 92, then the patient is not having any type of hyperglycemia. You should rescreen at 24 to 28 weeks. So fasting plasma glucose of less than 92, rescreen at 24 to 28 weeks. FPG 92 to 125, then GDM is diagnosed. FPG more than 126 for 2 times, then it is symptomatic diabetes mellitus. Now role of HbA1c is less actually in pregnancy because of what do you call, decreased RBC volume. So whenever there is some chedchad with this RBCs, either by hemolysis or by dilution or something which decreases their volume or production, like that, so their HbA1c has a less role to play. So even then, if HbA1c is more than 6.5%, then it is likely over type 2 diabetes mellitus, type 1 or type 2. If the HbA1c is 5.7 to 6.4, then it is a high risk case. You can't say it as GDM. Retest at 24 to 28 weeks. The main thing is fasting plasma glucose at first visit. More than 126, then it is overt. 92 to 126 according to ADI. So this came from? This is from American Diabetes Association classification. So 92 to 126, then it is GDM. Less than 92, so it is nothing. So screen again at 24 to 28 weeks. HbA1c has less role, but if HbA1c is more than 6.5, then it is symptomatic DM. But if it is 5.7 to 6.4, then it is a high risk. So re-screen at 24 to 28 weeks. Okay, so this is ADA classification. So there is one more classification which is more commonly used in India, which is known as DIPSI criteria for diabetes mellitus. What is DIPSI criteria? So no need of fasting. No need of fasting. What do you do? Morning you will give 75 gram of glucose to the pregnant lady, and after 2 hours you will take the glucose, and if that glucose level is more than 140 milligram per deciliter, then that is known as GDM. So this is the criteria which is mostly used in India. So this is non-fasting. What do you call? The pregnant lady will be non-fasting, and she will be given 75 gram of glucose, and after 2 hours the sample is taken. If it is more than 140, then it is GDM. So this is ADA. So if the patient now, if she is diagnosed that she is having diabetes mellitus, either it can be GDM or it can be diabetes type 1 or type 2. So what investigation should be done, and what is the concept behind those investigations? So FPG and 2 hour OGDT or DIPSI are usually required for diagnosis. Okay. Then HbA1c just to assess glycemic control. So less than 6.5% target in the first trimester. So same thing, serum creatinine, EGFR, UACR, TSH, lipid profile, urine routine culture, and fundoscopy, BP measurement. So these are common for all diabetes mellitus patients. Similarly, so this is common, no? So in non-pregnant individuals also will perform all these tests. Okay, so this is common. One thing to important here is BP measurement is important. Okay, that is done in non-pregnant also. So hypertension disorders, there is high risk of preeclampsia in these patients. And another thing about is fetal anomaly scan is very important at 18 to 20 weeks. Fetal anomaly scan 18 to 20 weeks, or you can take 5th month of pregnancy, 4 5 or 20, yeah, 5th month of pregnancy, T4 anomaly scan. Okay, so congenital anomalies, especially the cardiac anomalies, if the patient is symptomatic diabetes mellitus. So anomaly scan is very important, and growth scan is also very important. Okay, so these are the tests we should order if a patient is presenting with diabetes mellitus in pregnancy. Why retinopathy? Why nephropathy? Patient can be having nephropathy. TSH, because there is combo of thyroid, diabetes, and hypertension, meaning these come together. Lipid profile to assess dyslipidemia risk, routine culture to assess UTI risk. Ophthalmology, because there is a increased risk of progression of the retinopathy if she has retinopathy. Okay, and BP for high risk of preeclampsia. Now this is ADA suggested ADA diagnostic criteria. Remember, depending upon the risk stratification. Now depending on the risk stratification, this is ADA criteria. So all pregnant women should be at first ANC visit should have risk assessment, ADA. Okay, so it is different for India, because India at first visit all women should be screened either by ADA criteria like FPG and HbA1c, or by DIPSI criteria. That is one thing. Okay, so ADA suggests in pregnant women first ANC visit risk should be assessed. Like high risk or India, all women should be having FPG and HbA1c at first visit. If the woman is having fasting plasma glucose of more than 26 or HbA1c more than 6.5%, then she is having symptomatic diabetes mellitus in pregnancy, managed as pre-existing diabetes mellitus. Okay, if not, if she is having FPG 92 to 125, then it is GDM according to ADA, then start management accordingly. If FPG is less than 92, then retest at 24 to 28 weeks. Now low to moderate risk cases should be screened to 24 to 28 weeks. At 24 to 28 weeks, so ADA suggests two tests. One is oral glucose tolerance test, where you at least 8 hours fast should be there, and after that early morning 75 gram of glucose is given, and before giving the sample you take the glucose sample, and after 1 hour you take the sample, and again after 2 hours you will take the sample. That is OGT. Another test recommended by ADA is two-step. One is 50 gram glucose challenge test and 100 gram OGTT. Okay, now if the patient meets the diagnostic threshold, then GDM is diagnosed. If the patient does not meets the diagnostic threshold, again you should repeat at 32 to 34 weeks, only if the patient has high risk features. 32 to 34 weeks only if the patient has high risk features. Now see, same thing. What is that? One step OGTT and two step approach. So one step approach here is fasting. You will take the sample. If fasting is more than 92, then it is GDM. 1 hour if it is more than 180, then it is GDM. 2 hour if it is more than 153, then it is GDM. 92, 180, 153. So this is according to one step 75 gram OGTT, oral glucose tolerance test. So this is ADA and WHO criterion. One value abnormal is enough. Two-step approach is suggested by the ACOG. Okay, and so step one, what you will do, you will give 50 gram of glucose challenge test. Non-fasting, you will give non-fasting patient, you will give 50 gram of glucose at 1 hour. If the plasma value is less than 130, normal, no further testing is required. If it is 130 to 140, then proceed to step 2, meaning you should perform 100 gram OGTT. If it is more than 140, then it is abnormal. Again you should proceed to 100 gram OGTT. If it is more than 200, then it is GDM diagnosed. So remember, in easy way, in easy words, if 50 gram glucose tolerance test is at 1 hour, if it is 130 milligram per deciliter, if the value is this much, then nothing is required. If it is more than 130 but less than 200, then you should perform 100 gram oral glucose tolerance test. But if it is more than 200 in 50 gram glucose tolerance test only, then it is GDM diagnosed. Now what is this 100 gram OGDT? This is fasting, remember. This is non-fasting and this is fasting. Fasting, again the values depend upon two things. One is Carpenter constant, one is NDDG. Fasting value of more than 195 diagnosed, 1 hour of more than 180 diagnosed, 2 hour of more than 145 diagnosed, 3 hour of more than 140 diagnosed. So most of them use Carpenter constant classification. So this also can be used. So more than 2 values met, then GDM is diagnosed in 100 gram glucose tolerance test. Fasting 100 gram glucose tolerance test. Fasting value more than 95, 1 hour value more than 180, 2 hour value more than 155, 3 hour value more than 140. So any two of these, if it is present, then it is GDM. So that is about ADA. So what is Indian? So Indian is very easy. No fasting is required. Just Q 75 gram of glucose load. 2 hour plasma glucose you check. If it is more than 150, then GDM is diagnosed. If it is less than 140 but more than 120, then it is impaired and at risk. At risk, you should perform or repeat the test at 24 to 28 weeks. What is the advantage of DIPSI? Single step, non-fasting, feasible at all levels of healthcare, ideal for Indian primary care and rural settings. Now, as I said, HbA1c role in pregnancy. So less than 6.5% does not rule out GDM. A1c unreliable in pregnancy because of increased RBC turnover. More than 6.5% first trimester, then it is symptomatic diabetes mellitus. Target in established diabetes in pregnancy. So what is the role of HbA1c? If it is less than 6.5%, so it can be used as rule in for diabetes mellitus, but it cannot rule out diabetes mellitus in pregnancy, HbA1c. That is what. So more than 6.5% in first trimester, it's just symptomatic diabetes mellitus. And it is also used to set the target of pregnancy. So the target should be 6 to 6.5%. It should not go less than 6% because there will be risk of hypoglycemia. So HbA1c is not used to diagnose GDM, only to screen for pre-existing diabetes mellitus. Physiological increased RBC turnover in pregnancy falsely lowers HbA1c. That is the role of HbA1c. It is helpful in ruling in diabetes, symptomatic diabetes, but not ruling out, and for monitoring control of diabetes mellitus. Now, what is the management of gestational diabetes mellitus? So you can divide the management as step 1, step 2 as pharmacotherapy, step 1 medical nutrition therapy, pharmacotherapy, and next, yes, these two things. One is medical nutrition therapy and second is pharmacotherapy. Coming first to medical nutrition therapy and lifestyle, which is first line for all gestational type 2 gestational GDM. Okay. So what are the targets according to ADA and ACOG? Targets are fasting should be less than 95, 1 hour should be less than 140, 2 hours should be less than 120. Remember, 95, 140, 120, 95, 140, 120, 95, 140, 120. For diagnosing OGDT, 75 more than 95, more than 180, 1 hour and more than, I'm talking about diagnosing. Okay, just remember, targets less than 95, fasting, 1 hour less than 180, less than 140, 2 hour less than 120, 95, 140, 120. Okay. So medical nutritional therapy, lifestyle, diet, carbohydrate control, typically 35 to 45% of total calories distributed across 3 meals, and in between the meals she should have 2 to 3 snacks in order to prevent hypoglycemia and starvation ketosis, because most of pregnant ladies, they will have nausea and vomiting pregnancy, so they will not eat actually, and we will prescribe like iron tablets for these pregnant ladies, so they will have some gastric irritation like that like thing. So if we don't give snacks, they will not take, and they will be at risk of diabetic ketoacidosis, as pregnancy itself is a risk for having DKA. Okay. Exercise, so 30 minutes moderate intensity aerobic exercise most days. So you can take brisk walking or swimming. So this is brisk walk for 30 minutes. So monitoring is required. How do you monitor? You will take fasting glucose, 1 hour glucose and 2 hour glucose 4 times daily. Okay. Easy to remember is fasting glucose, 1 hour glucose and 2 hour glucose. And every 3 months you can take HbA1 also, and it should be less than 6.5% but more than 6%. So that is how you monitor. Okay. So exercise we have discussed, diet we have discussed, and monitoring and targets we have discussed. Now coming to pharmacotherapy. So insulin is the gold standard first line recommended drug for your GDM. One important thing, pharmacotherapy, when you should give indication, target glucose levels not met after 1 to 2 weeks of medical nutrition therapy. So first you will see whether the patient responds with medical nutrition therapy for 15 days. If she is not responding with medical nutrition therapy alone, then we will decide upon giving pharmacotherapy. So insulin the first line. Why? It does not cross the placenta, safest and most effective, requires education on injection technique and hypoglycemia management. Metformin is a second line alternative to insulin, or it can be given as an adjunct to insulin also. But the things are, it crosses the placenta, often used in PCOS or if insulin is refused or unavailable. May cause GI upset, often requires eventually insulin addition. Okay. Glyburide or glibenclamide, one more name. Glibenclamide is not recommended in pregnancy because it crosses the placenta. There is high risk of neonatal hypoglycemia and macrosomia compared to insulin. Not recommended by ADA or ACOG as first line. Okay. So insulin, metformin, glibenclamide is not used now. So how do you use insulin? So you will take one basal bolus multi-dose regimen will use. So preferred for pre-gestational diabetes mellitus and severe GDM. Basally, you can use non-hegemon protamine insulin, determinant insulin or glargine. For bolus mealtime, you can use ultra short acting like Lispro aspart or short acting like regular insulin. So what is the GDM starting dose? GDM starting dose is often lower when compared to other insulins, which is nothing but 0.5 units you use, but here it is 0.2 to 0.4 units. Remember one thing, one low, start low, go slow. Start low, go slow, meaning in dose. Start at low dose and titrate slowly. So 0.2 to 0.4 units per kg per day based on degree of hyperglycemia, divided into basal and prandial components. How? Half of insulin you will give as bolus in basal, and other half you will divide into 3: morning, afternoon and evening. Okay. So for example, if a lady is having is 60 kg and 0.3 if you multiple, that is 8 units actually. So 9 units you will give as basal. Okay. 3 units morning, 3 units afternoon, 3 units in evening. Now based upon the fasting plasma glucose 1 hour and 2 hour glucose, you will titrate the insulin levels. Okay. You can titrate similar to your type 1 diabetes, similar to other regimens. Like for example, if the morning glucose is high, then you should increase the basal dose. Now if the fasting glucose of afternoon is high, then you should increase the morning dose. If the fasting glucose of evening is high, then you should increase the afternoon dose. Now if the sleeping insulin 4 times, sleeping dose is high, while sleeping also you should check the glucose level. If the sleeping dose is high, then you should increase the evening dose. That's how you titrate the insulin levels. Okay. Now this is very important. Fetal surveillance. Growth scans every 3 to 4 weeks. Every month you should perform the growth scan starting at 28 weeks, meaning 7 months. From 7 months, meaning in third trimester. In third trimester, every month you should perform growth scan to assess for macrosomia and fluid volume, because they are at risk of polyhydramnios and macrosomia. So in the third trimester, every month growth scan should be performed in patients who are having diabetes in pregnancy. Antenatal testing. So 2 tests, non-stress tests, NST and BPP, biophysical profiles, should be started at 32 to 34 weeks, meaning at 8 months. Okay, for pre-gestational diabetes mellitus or GDM on pharmacotherapy. So NST and BPP should be performed, okay, at 8 months, 8 to 9 months, NST and BPP. Okay, and growth scans every month in the third trimester. Now, when should one what should be the delivery timing? So a GDM which is controlled on diet alone, so expected management should be given until 39 to 40 weeks. Expected management meaning, what is expected management? Expected management is nothing but you will allow the pregnancy to pass through a natural course. So you will allow the pregnancy to pass through a natural course with monitoring. So that is expected monitoring. So if on monitoring you detect something, you will take your decision, you will alter your decision. That is expected management. So a diet controlled GDM should have expected management until 39 to 40 weeks. Medically managed GDM should have delivery at either of the first day of 39 weeks or at the sixth day of 39 weeks. First day of 39 weeks or sixth day of 39 weeks. So medically managed. Pre-gestational diabetes mellitus, meaning a woman who is diagnosed in first trimester, or she was having type 1 or type 2 before pregnancy only. So she should deliver at 39 weeks, first day of 39 weeks or sixth day of 39 weeks. And even earlier if poorly controlled or complications detected. So if you detect macrosomia, meaning if the baby on scans, if it is more than 4.5 kgs, the normal delivery is not possible, you should plan for cesarean section, elective cesarean section to prevent shoulder dystocia. To prevent shoulder dystocia, you should have a elective cesarean section if you detect macrosomia on growth scan. Okay. So now what are the complications and prognosis? Maternal complications are, she is at high risk of preeclampsia and gestational hypertension, meaning pregnancy induced hypertension, that we should remember. High risk of C-section, high risk of polyhydramnios, high risk of diabetic ketoacidosis, especially in type 1 diabetes mellitus, can occur at lower glucose levels in pregnancy. And she will be having a future risk of type 2 diabetes mellitus, 50% risk within 5 to 10 years of GDM patients. So what are the fetal and neonatal complications? So you can divide it into a patient who is having overt diabetes mellitus, pre-gestational. So the baby will be having a risk of congenital anomalies like cardiac anomalies like ASD, VSD, like that, neural tube defects and caudal regression syndrome. So heart and spinal cord anomalies risk, or spontaneous abortion, that is pre-gestational diabetes. So GDM and pre-gestational both in second and third trimester. So first trimester complications are related to defects, birth defects and abortion. Second and third trimester in both GDM and pre-gestational, she will have a risk of macrosomia. Why macrosomia? Fetal hyperinsulinemia acts as a growth factor. Okay. At risk of shoulder dystocia or birth trauma during delivery. At risk of neonatal hypoglycemia. Why? Hyperinsulinemia persists after cord clamping. High risk of respiratory distress syndrome because of delayed lung maturation. High risk of hyperbilirubinemia, polycythemia, hypocalcemia. These three things. Metabolic complications. Okay. Respiratory complications. So these four things are metabolic complications: hypoglycemia, hypocalcemia, hyperbilirubinemia, and polycythemia. High risk of stillbirth, especially with poor control. She will lose the baby after 20 weeks. So these are the complications in second and third trimester: metabolic complications, respiratory complications, macrosomia, and stillbirth. 4 types of complications. Okay. So what are the pitfalls and common mistakes we make? Missed early screening, failing to screen high risk women at the first prenatal visit. Delaying insulin, spending too long optimizing diet or oral medications when glucose is persistently elevated, fetal growth accelerates quickly. So in that cases, so you should not delay insulin. Assuming that glibenclamide is safe, so that is a pitfall. Ignoring postpartum follow-up, this is very important. We should not ignore postpartum follow-up. Why? Failing to perform a 75 gram OGTT at 1 to 3 months of postmortem in women with GDM to rule out persistent type 1, type 2 diabetes mellitus. So postpartum screening is very, very important. Okay. Diabetic ketoacidosis misdiagnosis. Missing euglycemic or mild hyperglycemic diabetic ketoacidosis in pregnancy. Always check ketones if pregnant patient is unwell. Even if glucose is less than 200 milligram per deciliter, they are at very high risk of decay, even if the glucose levels are less. Using A1c for GDM management. A1c is poor for short-term adjustments. Rely on daily capillary blood glucose. Okay, so that is about very important things. Early screening is important. Don't delay insulin. Don't give glibenclamide. Postpartum follow-up should be there. OGTT should be performed at 4 to 12 weeks. DK misdiagnosis and A1c should not be used. That's all about GDM. Thank you.